All right. So for this, I'm going to talk about EKG rhythm changes. Now, for this, I chose this because I'm a nerd when it comes to cardiology and reading 12 leads. So in this presentation, my goals for all of you who will watch this is to know some causes of EKG changes, how to treat them, right? How do we treat them? The pathophysiology behind it. Why is this rhythm being caused? And the medications we use and more about them. So first, we're going to start off with the anatomy of the electrical system and the heart. So when we start, we have the SA node, the sinoatrial node. This is a group of specialized cells. This conducts an impulse through the intraatrial tracts, causing the atria to contract, push blood to the ventricles. Now, when it goes through the intraatrial tracts, it will reach the AV node, the atrioventricular node. Once he reaches the AV node, it goes through these tracks, reaching the bundle of his before it hits the bundle branches down here and further down into the Purkinje fibers, which all of these right here stimulate the ventricles to contract and push blood out. Right now, when your SA node is the primary pacemaker of the heart, conducting its rhythm in the heartbeat, your heartbeat's normally going to be around 60 to 100 beats per minute for a normal rhythm. Let's say the SA node fails. We're going to go to the AV node. The AV node is 40 to 60 beats per minute. Okay. If it's the primary pacemaker. Now, let's say the Purkinje fibers are the primary pacemaker because all this fails. It's going to be 20 to 40 beats per minute. So now we're going to talk about a little bit of heart anatomy and how blood goes through the heart. So you have your superior and inferior vena cava. This is your superior. It's blood coming from the upper portion of your body. Inferior is from the lower. So once it comes in there, this is deoxygenated blood that's coming in. It goes to the right atria. The right atria then contracts, pushing blood through this valve right here called the tricuspid valve into the right ventricle. The right ventricle then pushes blood through the pulmonic valve to go to the pulmonary artery, which takes it to the lungs. Once it gets to the lungs, it gets fully oxygenated. Excuse me. It comes back to the heart, oxygenated via the pulmonary veins. Pulmonary veins then goes to the left atria, goes through this mitral bicuspid valve to the left ventricle. Left ventricle then pushes it through the aortic valve out through the aorta to the rest of the body. Right. Now, little tip is your pulmonary artery is the only artery in your body that will carry deoxygenated blood. Your pulmonary veins are the only veins that will carry oxygenated blood. Every other vein in the body carries deoxygenated. Every other artery carries oxygenated blood. Okay. So moving on from there, this is where we get into the electrical activity and how it causes your electrical rhythm to show up on a 12 lead or a 4 lead when you hook them up to the heart monitor. Now, your P wave is caused by atrial depolarization. Okay. What this means is that when your sinoatrial node sends an impulse through the interatrial tracts, stimulating the atria to contract, while the atria is contracting, it is conducting this P wave. This is atrial depolarization, your P wave. Now, when it's stimulated through and you get that electrical activity in atria and your P wave may look sometimes you'll get what's called left or right atrial enlargement. Either your P wave will be taller than it should be or wider than it should be. That means there's some form of atrial enlargement going on, right? Now there's no normal time for a P wave, so there's no normal time for a P wave, so you don't have to worry about that. Next, we're going to move on to the PR interval. Now, it's not highlighted here in this image, but I will explain it to you. The PR interval starts at the beginning of the P wave, and it goes all the way to the beginning of the Q wave. Okay, it's the PR interval. Okay, I don't know why they call it PR when it's. I don't ask me. This is what I've been told. This is what I've been taught. This is what I'm going off of. Now, your normal PR interval is 12 to 0.12 seconds, excuse me, not 12, 0.12 dash 0.2 seconds. Okay. Now, each little box here is 0.04 seconds. 5 of these boxes, which makes a big square, 5 boxes equals 0.2 seconds. So if your PR interval is longer than 0.2 seconds, 5 boxes, 5 small boxes, there is something, there's probably a heart block going on, which I will explain later. Now, we have the QRS complex. This is ventricle depolarization. This is when the electrical impulse hits the ventricles, causing the ventricles to contract, making this QRS complex. Now, the reason why it's bigger than the atria is because the ventricles have more mass, so it takes more electricity. Not so much more electricity, it just the reason why the QRS is so tall and stuff like that is because the ventricles have to take more force to push more blood out because it's pushing um because it has to push it out to primary organs. So it takes a little bit more force. That's what I've been taught. That's what I've been taught. Now, your QRS complex is either going to be your normal range is 0.08 or 0.04, however you want to put it, to 0.012 seconds. Okay. Now, if it's wider than 0.12, there's a ventricular rhythm going on because it is taking longer to depolarize, meaning there's something going on with the ventricles. Okay. Now, we're going to talk about the QT interval right here. QT interval is right here. When the PR interval starts, where the PR interval ends, the QT interval starts. Starts here, beginning of the Q wave to the end of the T wave. Normal QT interval is 0.4 to 0.43 seconds. That's normal for men and women. Now, it may differ sometimes, like you'll have a woman like 0.46 or something like that. That can be normal. But if you have a longer polarization of your QT interval, there's some electrolyte imbalance going on, and I'll explain that. Now, last thing I want to cover of this part is ventricle repolarization, aka your T wave. So these all have to do with contraction, right? This has to do with relaxation. This is when the ventricles relax and get ready for another beat and get ready to contract again. This causes your T wave. Now, one I'll explain it later with the electrolyte, but one electrolyte that helps with that is your potassium. Potassium helps relax your ventricles to prepare for its next beat. So if you have a higher level of potassium, if you get too high, you're going to get those peak T waves because it's going to relax super fast, right? Notice how it's just like a kind of like a slow, right? But potassium is going to be peaked because it's a lot of potassium, so it relaxes faster than it should. All right. Now, you're probably wondering, since you have atrial depolarization, ventricle depolarization, ventricular repolarization, where is atrial repolarization? That is going to be hidden in your QRS right here. The same time the ventricles depolarize, the atria repolarize. So just remember that. Here are the changes I'm going to go over for causes of rhythm changes. These are the ones I'm going to go over for today because I feel as these to me seem the most common that I have found in the field. So I wanted to go over it. Premature beats. We have myocardial infarction, aka heart attack, is another word for it. We have a pulmonary embolism. We have atrial rhythms, supraventricular tachycardia, heart blocks, junctional rhythms, ventricular rhythms, bundle branch blocks, electrolyte imbalances, Wolff Parkinson White syndrome, pacemaker rhythms, and cardiomyopathies. So I will explain these and then show an EKG showing what changes it'll cause so it makes sense to you all. Premature beats is when the heart fires an impulse too quick that interrupts the rhythm. So you have 3 different types, as I put in this image down here. You have PAC, a premature atrial complex, PJC, a premature junctional complex, and a PVC, premature ventricular complex. Now, each of these are different. PACs will have P waves. I'll show you, but they have P waves, right? It's just when a beat happens too soon, right? So you have this normal sinus rhythm going, and all of a sudden the atria jump in front and immediately conduct the beat just like that. Like it shouldn't have because it interrupted, right? Now, PJC, you either have absent P waves inverted P waves, or something up here, which I put called retrograde P waves. Now, premature junction complex, same thing as the atria, except the AV node conducts a beat early. PVCs, premature ventricular complexes. These are wide complexes that have no P waves. Like they look ugly when you see them. It is very noticeable to see a PVC. Now, here's what I'm going to explain. Retrograde P waves. Retrograde P waves are P waves that appear in between the QRS and T wave. These are only seen in junctional rhythms. So in between the QRS and the T wave, if you see a inverted P wave, that is a retrograde P wave. That is what that is called. Only in junctional rhythms will you ever see retrograde P waves. PVCs are the only premature beat that have a wide QRS complex. PJCs are the only one with inverted P waves. Okay. Treatments for these O2 therapy and monitor EKG. Most of the time, the reason these premature beats happen is because the heart's pissed off in some way. Some way, shape, or form, those cells are mad. And O2 is going to help calm the cell down when it's irritated. That's what O2 is going to do. Now, first one here. Here are the premature beats I have right here. This is a PAC. Notice how it's beat way too soon. Because look, you have your P wave here, QRS there, and your T wave here. But look, there's the PAC. It gives no time for that next beat to form. Instead, it jumps in front, skips a beat. Notice has normal P wave, normal QRS, everything. It's just a beat that happened too soon. Now this is a PJC. Notice how the P wave is inverted. Same thing as atria, except the P wave is inverted. Right? Here's a PVC. This wide complex inverted T wave, like it just looks like crap. That's a PVC. PVCs are probably the most common one you will find in the field. PACs or PVCs. I haven't really seen much PJCs, but that doesn't mean they're not out there. Next is a myocardial infarction, okay, a heart attack. So this is a clot in a coronary artery. It could be your LAD, your RCA, it could be your left circumflex, whatever. It's a clot in your coronary arteries, one of them, blocking blood flow to the heart muscle. This causes your heart muscle to develop necrosis, aka your cells are dying. Basically, what happens in a heart attack is you got a clot in your coronary artery, decreases perfusion to that heart muscle. Your heart muscle then dies and releases a toxin called troponin. That's why they want your troponin levels because they tell you if you're having a heart attack. Now, signs and symptoms. Chest pain that radiates to the left arm, dizziness, fatigue, cool, clammy, diaphoretic skin, nausea, vomiting, and shortness of breath. Now, patients who are diabetics, they could have something called diabetic neuropathy, where they feel pain differently than most people because their nerves are shot up. So they could be experiencing foot pain, toe pain, their eye hurts, something out of the ordinary. You look at that 12 lead and it's a massive MI. I've seen it happen myself. It's possible. Women who experience MI may present more with back pain versus chest pain. I've always been told this, and me being me, I want to know why. So here, I'm going to give you the why as to why this is. It's something called referred pain. The nerves that are connecting the heart to the brain also connect to the upper back, causing the pain to be felt towards the back versus your actual chest because of the nerves. They call it referred pain. Treatment for the heart attacks. You want to monitor 12 leads, put the pads on them, right? Get ready because you got to limit scene time too. You got to get out. And there's an acronym called FONA we use to treat heart attacks, right? That's fentanyl, oxygen, nitro, aspirin. Fentanyl helps the patient with pain. Oxygen provides the cells in the heart with energy. Nitroglycerin decreases the workload on the heart, and aspirin prevents more clots from being formed. So that's how all this works on a heart attack. And here's what a heart attack looks like. This heart attack right here specifically, this is an inferior wall MI because 2, 3, and AVF have ST elevation. That's how heart attacks are going to present. Then you have your reciprocal changes in your lateral and your your septal leads. Also, one thing about that, caution giving nitro to inferior wall MIs, you may make it worse. So just caution with giving those. Now, pulmonary embolism. That is when there is a clot in the pulmonary artery constricting blood flow to the lungs. This leads to lung tissue damage, a low oxygen levels, it puts a strain on your heart, which could lead to heart failure. Okay. Signs and symptoms of it: shortness of breath, hypoxia, tachycardia, chest pain, pale, clammy, diaphoretic skin, and lightheadedness. Risk factors: patients with PE will have one of these risk factors 100%. Smoking, recent surgeries, sitting down for long periods of time, and long travels. Those are the common ones. Most cases with PE, the clot starts in the leg and travels to the lungs, aka it starts as a DVT, becomes a PE, right? Treatment for this is O2 therapy and pain management because ultimately they need surgery. They need to get they need a cath lab, they need to get that clot out. Now, how do we see this on an EKG? Because it's not directly a cardiac problem, but it does put a strain on the heart. How we see this on the EKG: tachycardia, right bundle branch block, and T wave inversion V's 1 through 4, V1, 2, 3, V4, excuse me. That is called right ventricular strain. And then RAD, right axis deviation. So here is a pulmonary embolism 12 lead. Notice you have your tachycardia, right? This is probably, let's say, 300, 150. Yeah, it's like 100, 110 beats per minute. You have your right bundle branch block. Then you have your T wave inversions right here, V1 and V2, and yeah, V1 and V2 got them. V3 and V4, not so much. But if you have a V1 and V2 with a right bundle branch block and a tachycardia, I'd be highly suspected of a PE. Atrial rhythms. This Here are the four atrial rhythms that I picked to go over: atrial fibrillation, atrial flutter, multifocal atrial tachycardia, and wandering atrial pacemaker, aka WAP. Atrial fibrillation is when the atria start to quiver, causing irregular beat fragments, increasing the risk of developing a stroke or a DVT, increases the risk of clots overall. Treatment for this is uh, cardizem or metoprolol, whatever your system carries, preferably cardizem. Cardizem converts the rate in the rhythm because calcium promotes excitability and irritability in the cell, causing your atria to quiver because it's excited and all this stuff. You know, when you're excited, you like get all this and stuff, right? Your atria do the same thing. So cardizem is going to stabilize that out because it's a calcium channel blocker. Metoprolol only fixes the heart rate part of it, right? Because it's a beta blocker. Now, moving on to atrial flutter. It's a form of SVT. It occurs when there's a reentry circuit in the right atria. Treatment's the same thing as AFib. Exact same thing. Multifocal atrial tachycardia, a rapid irregular rhythm within the atria, is caused by multiple ectopic foci, meaning multiple beats. Usually found in patients with COPD or CHF because their heart's pissed off. Treatment, same thing as AFib. Now, wandering atrial pacemaker. So when the atria takes over the SA node as the primary pacemaker of the heart. So now the atria is beating for itself. Treatment is the same thing as AFib if they're symptomatic. Some people live with WAP and they live fine. So here's where we look. First thing, this is AFib right here. Notice how the complexes are irregularly irregular. Okay, that is AFib. This is a flutter. Notice how it's going really fast and it's got those flutter waves, is what we call it. Flutter wave, flutter wave, flutter wave, flutter. Yeah, that's a flutter wave. This is multifocal atrial tachycardia. The P wave changes every beat. Look at its morphology of the P wave. It changes. Every beat that happens, the P wave changes. Last one, wandering atrial pacemaker, aka WAP. You will start to have beats like these or like these, right? Where they're really close together. It looks similar to AFib, but it's only got like a couple premature beats. This next one, I can't get this freaking thing to go away. I'm sorry. Supraventricular tachycardia. This is when your heart rate is too fast, like it gets above 150 beats per minute. Usually it becomes SVT. It starts in your atrium. It makes it harder to pump blood adequately through the body because your heart's beating too fast. Signs and symptoms is chest pain, diaphoresis, lightheadedness, feeling dizzy, and dyspnea. It can lead to heart failure or cardiac arrest. Treatment: start with vagal maneuvers. You want to activate that vagus. If they're, let's say they're like me right now, they're ANO times 4, blood pressure's everything fine. You put them on the monitor, heart rate's like 180. You're going to start with vagal maneuvers. Vagal maneuvers are going to activate that vagus nerve to release acetylcholine to lower the heart rate. If that doesn't work, you're going to move to adenosine if they're still stable. Adenosine is believed to be a sodium channel blocker. It blocks conduction through the AV node. That's what it does. Cardizem and metoprolol if adenosine doesn't work and they're still stable. Cardizem works on phase 2 of the action potential, causing longer repolarization. Metoprolol works on phase 4, causing your heart rate to decrease. Unstable treatment is cardioversion. Cardioversion shows a jolt of electricity in the cardiac cycle that resets the heart, right? It interrupts that rhythm. This is SVT. You got narrow QRSs, no P waves, and the heart rate is fast. That's SVT. Now, moving on to heart blocks. You have first degree, second degree type 1, second degree type 2, and third degree. First degree is when your PR interval is just longer than 0.2. That's it. There's really no treatment for this because people live with this just fine. Just monitor and make sure they don't go into a worse heart block. Here we are. Second degree type 1 is when your PR interval gets longer and longer and then the beat drops, like your heart drops a beat. Treatment for this is transcutaneous pacing. It sends jolts of electricity to your heart, primarily the SA node, and takes over as primary pacemaker of the patient's heart, right? You're pacing for the patient. You're beating their heart. That's your job. Second degree type 2, the PR interval stays the exact same length, but the heart randomly drops a beat. Treatment is the same. Okay. Third degree, when the P waves beat at a constant rhythm and the QRSs beat at their own rhythm, but they don't pair. So your P waves are marching on their own, your QRSs are marching on their own, but they're not conducting well together. They're not matching. Okay. Treatment's the same. This is a first degree. All you really have here is your PR is longer than 0.2. That's all you have. Next one. This is second degree type 1. Look down here in lead 2. Your PR right here is longer, drops a beat, does the same thing. Second degree type 2, the PR stays the exact same, but a beat drops out of nowhere. And last one, this is a third degree. You have wide complexes. This looks ugly. It looks like a ventricular rhythm. This is third degree because you have a P wave here, P wave there, P wave there, P wave there, P wave there, P wave there. Like they're beating on their own. The QRSs are beating on their own, but they're just not matching. Next is junctional rhythms. Now, junctional rhythms happens when the SA node fails. The AV node takes over as a primary pacemaker. Heart rate, like we talked about earlier, is 40 to 60 beat per minute, usually with a junctional rhythm. These rhythms either have no P waves, retrograde, or inverted P waves. If they're symptomatic, treat them with atropine. Atropine blocks the parasympathetic nervous system response in the body and instigates the sympathetic nervous system. It also works on the AV node to increase conduction through it. Accelerated junctional, same thing as junctional rhythm, exact same thing, but the heart rate is 60 to 100 beats per minute. Treatment for accelerated junctional and JTAC is manage signs and symptoms if they're symptomatic. JTAC is the same thing, except their heart rate is higher than 100 beats per minute. This is a junctional rhythm. Notice how you have your P wave here. That, what I talked about earlier, is called a retrograde P wave. Those are your retrograde P waves. Next one here. This is accelerated junctional. The heart rate's around 60 to 80 beats per minute, but the P wave is sometimes before, inverted, after, whatever. This is JTAC. There is no P wave to be found. Heart rate's higher than 100 beats per minute. That's JTAC. Now, ventricular rhythms. I have monomorphic VTAC, VFib, torsades, idioventricular, and accelerated idioventricular. Monomorphic VTAC. This is when the patient's ventricles take over the primary pacemaker of the heart and they beat really fast, causing decreased perfusion and low cardiac output. Treatment includes amiodarone drip or cardioversion if they have a pulse. But if they don't have a pulse, activate cardiac arrest protocols, meaning CPR, BVM, all that good stuff. You know how cardiac arrest works. Amiodarone works by inhibition of potassium rectifier currents responsible for repolarizing the heart during phase 3 of the cardiac action potential. This potassium channel blocking effects result in increased action potential duration and causes a prolonged refractory period in the cardiac myocytes. Myocyte excitability is reduced, thus hindering the continuation of tachyarrhythmias by preventing re-entry mechanisms and ectopic foci. Now, next is VFib. Okay. VFib is when the ventricles are quivering. This causes little to no cardiac output. Treatment is cardiac arrest protocols because they're automatically going to be in cardiac arrest if they have VFib. Now, this one is torsades. This is polymorphic VTAC. This is a form of VTAC. Basically, it's the same thing as VTAC. The difference between polymorphic and monomorphic VTAC is that monomorphic, the impulse is coming from one spot in the ventricle the entire time. Polymorphic, so excuse me, monomorphic is coming from one spot in the ventricle. This causes the QRS complex to look the exact same every time. I'll show you. Polymorphic means the impulse is coming from different places. The QRSs are going to look different. Treatment for this is cardiac arrest protocols, but give MAG to these patients. Hypomagnesia is the most common cause of torsades, so give MAG to these patients. Idioventricular rhythm is when the ventricles take over as primary pacemaker of the heart. The heart rate will be around 20 to 40 beats to rhythm. There'll be no P waves and a wide QRS complex. Treatment for this is atropine or epinephrine pressor if they're symptomatic. Now, atropine may so much not work. You can give it and try it. It's worked one time when I've seen it, but mainly I've seen people just do an epi drip. Just do an epi drip. It works fine. Now, for this one, accelerated IVR. Same thing as idioventricular, but the heart rate ranges from 40 to 120 beats per minute. Treatment is manage signs and symptoms if they're symptomatic, right? This is monomorphic ventricular tachycardia. Notice how the QRS complexes look the exact same every time. The impulse is coming from one spot. This is VFib. It looks ugly, right? It looks like a 2-year-old scribbled on a piece of paper. This is torsades. Notice how it gets bigger and then smaller and then bigger. It looks like a party streamer. You ever see those party streamers? It looks like those, right? That's torsades. Idioventricular. This is what it looks like. Y complex is really slow heart rate, no P waves, right? This is accelerated IVR. Same thing except the heart rate's higher. Bundle branch blocks. You have a right and a left bundle branch block. Right bundle branch block is when it's blocked, causing longer depolarization and delayed response. There's no real treatment for this but monitor because most patients live with bundle branch blocks. Causes for this, though, is myocarditis, trauma, heart attack, and Lev's disease. Lev's disease, aka Legionnaire's disease, is when the left and right bundle branches degenerate. This leads to a permanent block. Now, left bundle branch block. This is the one we're more worried about because it's one of the imposters of a STEMI. That's why we have a thing called Scarbosa criteria. This is when the left bundle branch is blocked, causing longer depolarization time of the heart. There's no real treatment for this, but monitor and find the cause if possible, right? Be aware of a possible heart attack because these things could mask a heart attack. The causes of this is, of course, heart attack, coronary artery disease, heart failure, pericarditis, hypertension, and congenital heart defects. Now, this is a right bundle branch block. You'll have something called an RSR pattern. So, it's not the best example for it, but I'm going to use it. So, you'll have a small R wave, a big S wave. Excuse me, I said that wrong. So with right bundle branch blocks here, right, you're going to notice that down, up, down pattern. So it's going to start a little bit down, going up, going back down, and then back up. You'll notice that. You'll look at V1 for these. V1, V2 will tell you if you have a bundle branch block. Moving on to the left, you'll have a Y complex. The complex deflection is negative, and you have Y complex, negative deflection, right? Bundle branch blocks have Y complex. If it is not a Y complex, it is not a bundle branch block. It is on its way towards one, possibly, yes, but it's not one yet. They call those incomplete right bundle branch blocks or incomplete left bundle branch blocks. Moving on, this is the one I added a lot to. This is electrolyte imbalances. I feel this is the most, in my opinion, one of the most important ones you need to know. So we have hyper K, hypo K, hypomagnesia, hypocalcemia, hyponatremia, and hypercalcemia. These are the 6 that I've seen in the field. I haven't seen anything else. Hyper K is when your potassium levels are too high, right? They're above a serum of 6. Excuse me. This causes your heart to depolarize longer. It leads to wider complexes. Treatments for this is bicarb and calcium chloride or gluconate, whatever your system carries. Sodium bicarb lowers the potassium levels. It alkalizes the blood volume systemically. So basically, it shifts the potassium and hydrogen levels, shrinking the complex. Basically, it takes potassium here, hydrogen here, swaps them. That's what bicarb does. It causes an intracellular shift. Intracellular shift. Now, calcium chloride and gluconate don't exactly work with potassium. All they do is they don't work by stabilizing potassium levels. They don't lower potassium levels. They stabilize the cardiac membrane. They make it less permeable. So that way it protects the heart muscle from bad detrimental effects of high potassium. That's what calcium does. Now, hypo-K, this is when your potassium levels are too low, causes your heart to take longer to repolarize, taking longer to relax, leading to a flat T wave, right? Treatments for this is fluids, preferably LR. LR has more electrolytes in it than normal saline, so it's better for these patients who are in hypo states of electrolyte imbalances. You prefer to give LR. If they're hyper, you prefer to give normal saline to dilute it. That's why lactated bringers works better. Now, hypomagnesia. Magnesium levels are too low. This causing electrical activity of the heart to get disrupted, causing the rate to speed up and become an arrhythmia. The most common is torsades, which you talked about earlier. Treatment is MAG. You want to give the body MAG if they're low on MAG, right? We don't carry potassium on our trucks. We don't carry calcium on our trucks, except for calcium chloride. You can give calcium chloride for hypocalcemia. I did not put it in there. I should have. Um, but we don't carry potassium on our truck to give. We only carry channel blockers of that, which doesn't preferably give it. Most common arrhythmia is, of course, torsades. You want to give these patients MAG. It stabilizes the heart out and the electrical rhythm, maintaining homeostasis. Hypocalcemia, calcium levels are too low. This causes your heart's electrical activity to send low amplitudes, leading to a prolonged QT interval. This causes your blood pressure as well to get higher because calcium can stabilize and manage your blood pressure. This leads to cardiovascular disease. Treatments include fluids such as LR to increase calcium levels. Also, you can give calcium chloride to these patients to feed them calcium. They need calcium ultimately. And then manage signs and symptoms. Hyponatremia. Sodium levels are too low. This causes your heart to develop changes like ST segment and T wave changes. Treatments for this is IV fluids, basically LR. Just give these patients LR. Hypercalcemia. This is when calcium levels are too high. This causes changes to such as a short QT interval due to too much calcium, so you develop fast contractions. Treatments for this is IV fluids. This is the one where I talk about where I prefer normal saline because it dilutes the extra electrolytes. It can help dilute some of it. Now, this is what I put down here. Hopefully, this will help y'all. Electrolytes are important for the heart's electrical signals and muscle work. This is how each electrolyte works. Sodium starts and spreads the signals throughout the heart. Potassium helps the heart relax. Calcium and magnesium help the heart contract and relax. All right. Now, this is hyper K. Notice those peak T waves, the development of sine waves. This patient's potassium level is probably about an 8 or 9, probably high 8s, closer to 9, because it's leading towards that sine wave pattern. This is hypokalemia. Notice the flat T wave right here. You get flat T waves and something called a U wave, right? This kind of looks like a U. That's basically what it means. This is hypomagnesia, right? See, notice here. Notice how it beats regular about here, then it gets to this, right? This is your heart's pissed off. The magnesium levels are disrupting the heart's electrical activity, causing impulses like these. This is hypocalcemia. The way you're going to see this on a 12 lead is prolonged QT interval. This QT interval is going to be longer than it should be. That means your calcium levels are too low. Now, this is hypercalcemia. Excuse me. This is hyponatremia. I forgot we're going over. It's hyponatremia, right? This is where you're going to see morphologies of the T wave and the ST segment. So the ST segment is going to look longer than it should, and this T wave is going to have a little curve, right? Notice how with normal T waves, it goes like up and like this. This goes kind of slanted at an angle. That's hyponatremia. This is hypercalcemia. The QT interval is short, right? It's really fast. That means your calcium levels are high. It's conducting fast contractions. Now, this is Wolff Parkinson White, WPW. This is when you develop an extra pathway in the heart. Signs and symptoms of this is anxiety, chest pain, dizziness, fatigue, syncope, dyspnea, shortness of breath, and heart palpitations. You may develop different arrhythmias from this, such as AFib, Epstein's anomaly, and VFib. Epstein's anomaly is when the leaflets of your heart valves, right, those flaps that open up, they get stuck to the wall of the heart. And they're also, the heart valves are misplaced and they sit lower towards the ventricles than it normally should. Treatment for this is a drip, such as amio or cardioversion if unstable. Do not give these patients calcium channel or beta blockers. These calcium channel and beta blockers work directly on the AV node, but due to WPW having an accessory pathway, meaning it skips the AV node because of that accessory pathway, it bypasses it, so it will have really an effect on it. WPW produces something called a delta wave due to the accessory pathway. The delta wave is this wave right here. Notice how most QRSs it goes straight up diagonally. This one curves, right? You can notice a slight curve here, right? It curves. That's a delta wave. That's what you see in WPW. Pacemaker rhythms. I'm almost done, I promise. We have atrial pacemaker, ventricular pacemaker, dual chamber pacemaker, and Erbsation. Atrial pacemaker is when the atria fails, so an implanted one is put in the patient and set to pace them at a certain rate and time in the cardiac cycle. You'll see pacer spikes. Ventricular pacemaker is the same thing, but for the ventricles. Dual chamber is when both the atria and ventricles fail, so a pacemaker is one and put in to send signals to both. Erbsation for this is when the ventricles try and take over and produce a beat on its own. This is directly related to pacemakers because I'll show you why. This is atrial paced. Notice how the pacer spikes are here before the P wave develops. That's atrial paced. This is ventricular paced because it comes after the P wave, meaning there's no P wave developed and it's got Y QRSs. Y QRSs are indicative of a ventricular arrhythmia. Just a heads up. This is dual chamber because you got double pacer spikes, one before the P wave, one after the P wave. This is Erbsation. This is directly related to paced rhythms because this commonly happens with implanted pacemakers when they set off at the wrong time. That's why you have these pacer spikes here. That is called Erbsation. Last one, cardiomyopathies. You have 5 of them. Hypertrophic, dilated, restrictive, left ventricular non-compaction, and Takotsubo, aka broken heart syndrome. Hypertrophic cardiomyopathy is when the heart muscle becomes thickened. It makes it harder for the heart contract and push blood out. Primarily shown on an ECG is with LVH, left ventricular hypertrophy, and large QRS complexes. Dilated cardiomyopathy is when the heart muscle is too thin and gets stretched out, growing larger and larger, making the heart unable to pump blood as strongly as it used to because it's thin and stretched. Shows on an ECG with poor R wave progression, left axis deviation, and low voltage. Restrictive cardiomyopathy is when the walls of the heart are rigid. The heart is then restricted from stretching out and pumping blood effectively like it should. Shows on an EKG with T wave changes, ST segment changes, and low voltage. Left ventricular non-compaction. This is when the left ventricular doesn't develop properly at birth, making it harder for the body to get effective cardiac output and push blood out. Shows on an ECG with prolonged QT interval, left bundle branch block, and increased QRS voltage. Takotsubo cardiomyopathy, aka broken heart syndrome. This is when your heart muscles suddenly get weak and have a hard time contracting strong enough to pump blood out. Shows on ECG with ST segment elevation. Treatment for all of these is manage signs and symptoms and monitor their EKG. Okay. This is hypertrophy cardiomyopathy. Hypertrophic. Notice here you have LVH because of the QRSs here. They're big. And you have T wave changes. You have T wave inversions, right? This is hypertrophic because it's showing with LVH as well as high QRS voltage. Next, this is dilated cardiomyopathy. Look how big those QRSs is. Good God, they're big, right? So if we go back here and look, we notice that large QRS complex with LVH, that's hypertrophic. This is poor R wave, low voltage, left axis deviation. So if you look here, you have left axis deviation here. Actually, no, you don't. You have right axis deviation. Okay. Well, this is dilated cardiomyopathy. The only reason why is because if you notice in V2, V3, V4, they all have long QRSs. The ventricle is stretched out, stretched, right? This is restrictive. Notice how you have low voltages here. The QRSs aren't really that tall. And you have T-wave changes and ST segment changes. That's restrictive. Left ventricular is, good God, those are tall, right? The V4, V5, V6, all your V leads will usually have tall QRS complexes, right? That's indicative of left ventricular non-compaction. Last one here. This is broken heart syndrome. It looks like a heart attack. Here's how I figured it out. If you look at the ST segment elevation for a normal heart attack, notice how when you go up with the ST segment, you have that line right there. Your ST segment line is straight, and then it goes down to a T wave. With this, look how this does it. It goes down, and then it goes up for the T wave. That's how you can tell it's broken heart syndrome. That's how I figured it out, right? So that's all I have. I hope you enjoyed it as well.